Good afternoon, friends and dear colleagues. Myself, Dr. Aditya Ulekar, Secretary of AOI ENT Surgeons Association of India, Pune branch. As a part of our monthly ENT teaching activity, today we have planned for you a topic which is very relevant as of now, that is robotics in ENT, present and future. In the era where precision matters, the applications of robotic surgery have multiplied steadily over the past 2 decades. Transoral robotic surgery, also called as TORS, has widened up newer vistas in ENT. The promise of TORS not only appeals in sleep surgery but is consistently on rise for head and neck cancers like base of tongue, oropharynx, larynx, thyroid, neck dissections, and much more. To share and update in this fascinating field, today we have with us world authority and expert mentor, Professor Claudio Vicini from Italy. We also have Professor Filippo Montevecchi from Italy. The Indian experience and inputs will be offered by robotic surgeons from India, Dr. Kalpana Nagpal from New Delhi, Dr. Shailesh Kotharkar from Nagpur, and Dr. Vishal Rao from Bangalore. Our international moderator for today is Dr. Sharmela Sondhi, who is a senior and experienced ENT surgeon. Now, our president of our branch, Dr. Vijay Sonane, will say a few words.
Thank you, Aditya. I welcome you all members, friends, and colleagues who have joined today's webinar. I also welcome our esteemed guests and expert panel for today's webinar, who have joined us from India and abroad. Dear friends, like last month, where we discussed a new concept in rhinology, that is hybrid endonasal rhinoplasty. This month too, we thought of bringing a new concept and advances in surgical treatment in ENT, and that is robotic surgery or robotic assisted surgery. Robotic surgery, introduced long back in the late 80s and 90s, extensively used in abdominal surgeries and joint replacement surgeries. Its use in head and neck and ENT has recently gained a lot of interest. A form of minimal invasive surgery, robotic assisted surgery, allow better access to traditionally hard to access part of the body and improve accuracy and precision in procedure. Today with the esteemed panel, we will discuss the present scenario and of robotic surgery and its future role in ENT and head and neck practice. Our young and dynamic secretary of AOI Pune, Dr. Aditya Ulekar, who has taken all the efforts to organize this event, along with Dr. Sharmela Sondhi, who is an esteemed life member of AOI and a senior consultant with Ministry of Health, India, Saudi Arabia, and Oman, will today moderate this session for all of us. I once again welcome you all and thank you all for joining today's webinar. Aditya, you can take over.
Yes. So here today we have an audience right from the residents to ENT surgeons to super specialists. So I would just like to tell everybody that this is a kind of robotic system that is there in place all over the world. That is the Da Vinci robo system. It has three parts. One is the surgeon console. Other is the robo itself. It traditionally has 4 arms for surgical and other, but ENTs use ENT and sleep surgeons usually use 3 arms, and there is a 3D console in the OT itself. Now, this is how TORS, that is transoral robotic surgery, works. There is a 3D camera arm and 2 ports simultaneously by which you can work. So what is the advantages? What has been studied? I did some research as well, and I found that the precision is more as compared to conventional surgery. There is haptic feedback. There is 3D visibility. The range of motion is more, that offers dexterity. That is tumor tremor is filtered. So tremor filtration is an important point, and the reduction in the morbidity of radical chemoradiation is now better offered by surgery, and this is one of the forms of organ preservation surgery. With this, I would like our moderator, Dr. Sharmela Sondhi, to take over. She is an advisor to Indian Medical Association. She is an AOI Life member. She has wide experience in ENT, working in Ministry of Health in India, Saudi Arabia, Maldives, Seychelles, and Oman. She has been taken up a course with in SDBS with Professor Vicini and Dr. Montevecchi. I like her to come in and introduce our international speakers for today before we proceed on to the lectures.
Namaste. Thank you for the introduction, Dr. Yevlekar. It's a great honor and privilege for me to introduce the international faculty for the webinar today. Professor Claudio Vicini, the pioneer of TORS, or Transoral Robotic Surgery, who is the Director, Department of Special Surgery and Head of Otolaryngology and Head and Neck Surgery at the GB Morgagni and L. Pierantoni Hospital at Forlì, Italy, and Professor Filippo Montevecchi, ENT consultant at Ospedali Privati Forlì, who has been an important member of the team with Professor Vicini at the same hospital in Forlì, Italy. Our distinguished faculty for robotic surgery in ENT, Professor Vicini, has held numerous posts, and I shall name just a few of them. President of the AOOI SIO of Italy, a board member of AIMS Committee for Sleep Disordered Breathing Surgery and Sleep Medicine, and professor in the University of Parma, Pavia, and Bologna in the field of maxillofacial surgery, rhinology, audiology, and vestibular medicine. He is a global faculty board member of the Florida Hospital Nicholson Center and the Intuitive Europe Proctor for TORS. Our esteemed faculty, Professor Filippo Montevecchi, is a robotic surgery instructor and ENT consultant at Ospedali Privati Forlì after a long period of 15 years as consultant at the GB Morgagni and L. Pierantoni Hospital at Forlì, Italy. He has been trained in Italy and Netherlands. He is a member of the SIOE-CHCF in Italy, the International Sleep Surgery Society, and a visiting consultant at the Hamad Hospital, Qatar. I had the opportunity to visit Forlì for a week for a course, the STS course, with Professor Vicini as the mentor. It was designed to provide an extensive background in the fundamentals of sleep disordered breathing surgery through the medium of lectures, small group hands-on procedures, after a period of intensive online learning and independent study. It was a dream come true for me to be an observer in the theater and watch Professor Vicini and Professor Montevecchi perform robotic surgeries. With this brief introduction, I would like to invite them to share their journey in robotic surgery in ENT with us.
Yes. So before Professor starts, I would like a senior ENT surgeon from Pune who is closely associated with Professor Vicini to say a few words. So hand over to Dr. Simab Sheikh.
Thank you, Aditya. I think we should not be wasting too much time with too much ado. Sharmila has given an extensive introduction. I can only say welcome, Professor, and welcome, Filippo. My association with the professor has been for about 5-6 years, and besides whatever Sharmila has said, I must tell you, although it sounds very cliched, but he is one man who not only teaches, but also tends to learn every step of the way. And every step of the way, if you interact with him, you learn to think in a very different manner. And I've seen that with Filippo, who's pretty much our contemporary. And I thank you, Filippo, also. So this time we made sure that we're not waking you up at 7 in the morning as we did for our ISSA web series. And Professor, thank you very much. I know, I mean, this is my hometown. This is my home city. And the one next week is the one that we're going to do differently. And that's why we've kept you away from robotics there. And while you're doing this, I will go and do some little bit of OSA. And Sharmela has been a part of our college. She has graduated as a senior to me. And it's pleasantly surprised to meet her in one of our international meets. And then we've been close. So without much ado, Professor, welcome to my city. Welcome to our hometown. I wish I could have had you here in person, but I guess that's going to wait for a few years now, or maybe at least a year. So thank you very much for taking our invitation, and over to you.
Thanks.
Professor, you can start your slides sharing now.
Thank you. Thank you so much to all of you. You may have a full screen my presentation. Sorry, I have to change. A special mention to, thanks to all of you, but a special mention to Sharmela. Sharmela spent some time with me. She's an excellent surgeon, and so I'm indebted to her because she's a great surgeon, and we had many occasions to interact in the last years. What I try to do with Filippo in the next half an hour, to share with you about 12 years of TORS experience in my unit. I try to share with you my experience, our experience with our papers. We wrote many papers. We selected some of them in order to give you an idea about what we did in the last few years. That's our situation in 2008.
Professor, we are not yet seeing the screen.
Can you see the screen?
No, not yet.
Oh.
You have to share screen.
I did. It's okay now?
No.
Not yet. You close your presentation, open it again, and then you can share again.
Okay, I'll do. Because it was already sharing. Don't know why.
Yeah, it was there already.
Yes. Now you're good.
It's okay now?
Yes.
Yeah.
Now it's okay?
Yes. Perfect.
Okay. Let me scroll quickly the first slides. Now, can you see now my slide?
Yes.
Okay.
Go back to Claudio. You can push the button to full screen, if possible.
It's okay now?
Yeah, better. Thank you.
Okay. Let's go to 2008 when we started our experience. After the experience in my hospital of general surgeons, urologists, and thoracic surgeons. We were the last of them, but we were lucky because we could use their experience. Our training started on January 2008 with theory. We started with studying a lot of paper, a lot of books. We spent many hours working with the machine in order to know how to manage the single pedal, the single button. And then we spent some time, I strongly suggest for the rookies to spend some time with Mankin in the OR in order to improve the possibility to obtain the best layout and learn how to work for docking the robot in the Mankin. And then spend as much as possible your time in cadaver dissection and pig dissection. Cadaver for reproducing surgeries, pig lab in order to try to learn how to manage bleeding. Another very important step was for us to spend some days in Strasbourg with a special instructor like this gentleman, David, who was able to teach us all the secrets, all the tricks, how to manage, how to expose at the best oropharynx, larynx, and also how to perform a total laryngectomy. The key point is to have a good teacher. My teacher was Greg Weinstein in Philly University, Penn University in Philadelphia. And our stay there was a crucial point for starting. And that day was a very special day for my team. It was March 2008. It was the team of that time. At that time we could run the first operation. After that, we could improve our experience that right now include 641 cases till July 7th of this year. As I try to show you, we could collect experiences, many different surgeries, but especially in the area of tongue base. The most common procedure in my hands is tongue base reduction, supraglottoplasty for sleep apnea, 335 cases. After that, we could perform a significant amount of lingual tonsillectomy for repeated infection and also for severe hypertrophy. We did a significant number of tongue-based cancer for resect a huge cancer or for performing mucosectomy in cases I'll show you of a non-primary. And then we have some special case like lingual thyroidectomy or lingual lymphoma resection. Overall, we could collect 523 tongue-based procedure. The most common procedure in robotic for cancer is a removal of squamous cell carcinoma. And the most common approach is to use a transoral approach for resecting superficial carcinoma of the tongue base, of the tonsil, of the posterior pharyngeal wall, on the supraglottic larynx. That's probably one of the most common application. And we have two different philosophies for approaching this kind of tumor. If you approach small tumor, T1 and T2, and you can obtain free margins, you are able to avoid radiotherapy. That is a great deal because you can use just a single modality in order to clear your patient, to address your patient. If you have to approach a bigger tumor, T3 and maybe sometimes T4, you may have a close or positive margin. In this case, you have to apply also radiotherapy, but in most of the cases, it's possible to apply de-intensified adjuvant therapy. That is another step forward in the approach of this cancer. Let me share with you this very short video. I just stopped the video when it will be sufficient. You can see here the cancer and the node in the neck with the CT, another section of the same cancer. And here you find the typical setting of transoral robotic approach to the tongue base. The blade, two instrument, a round tip cautery, and a Maryland forceps. Is a 5mm instrument, and the header system help you stretching the tissue with this couple of suction tubes. If necessary, we can prevent bleeding with a preliminary coagulation with this C forceps, is a bipolar forceps. You have a very interesting view. You have a wide field overview of the surgical field. Any single structure is under control. Is the best approach you may have in the tongue base from the oral cavity. We could write the first paper about our experience in 2019. At that time, we collected 60 patients. And what was the main concept of this paper is that we could obtain a significant survival rate irrespective to the dimension and to the HPV status of the patient. Again, we could produce an additional paper, it's just published, in which we could compare in our hands, in our experience, compare the outcome of robotic surgery and a definitive chemoradiotherapy in a group of patients, 60 patients for surgery, a 69 patient treated by chemoradiation. And what we could demonstrate that overall survival, disease-free survival, local recurrence-free survival, and regional recurrence-free survival was comparable. So TORS was proved to be not inferior to chemoradiation that so far was considered the golden standard for this kind of cancer. These are the survival curve of the two different modality. And you will see that in many subgroup of patients, the superiority of surgery compared to chemoradiation. Another very important application of robotic surgery in our hands was the approach to a non-primary with positive node in the neck. What we could demonstrate is possible to... Can you hear me?
Yes, yes.
Okay, I have some noise in the background. We can approach with a mucosectomy. We remove the entire tongue base, the entire surface of the tongue base. In this way, we obtain a double goal. First of all, to locate the tumor. And the second point is to avoid over-radiation of the patient that may produce very bad situation in a long time. If you compare imaging with robotic surgery, robotic mucosectomy, in finding the small tumor in the tongue base, you will see that this is our group meta-analysis, that the capability of TORS is much more interesting than imaging. In our group, in our experience, we could obtain a success rate of detection about 67%. That is a very high rate of detection of the cancer. In the same area of cancer of oropharynx, we introduce a special way for emphasizing intraoperative superficial margin in order to perform the best resection as possible. Our goal is to get a negative margin with the first resection. Otherwise, we have to send frozen section to check the margins are clear. And if not, you have to go back to the patient to resect additional section. So in order to improve our capability to perform an initial radical section, we used to work in this way. It's an endoscopy performed at the very beginning of the procedure. And switching to NBI, we can precisely locate the margins of the superficial margins of the tumor, and we can mark in this way. We can mark, and in this way, we will obtain the perfect outline of the resection lines since the beginning. This is the way we can check if the limits were okay or not. If not, we can extend the marking, and in this way, extend the resection. Working with this approach, so using together in the same time NBI and robotic, we could demonstrate that, it's our paper, that the success rate for obtaining free margins since the first resection is much higher, 90%, than may happen working without marking with NBI. So NBI enhance your capability to perfectly resect the tumor since the beginning. So the prediction of a free margin is much higher, and the system is very useful. Another problem that we try to introduce and to address in our experience is how to reconstruct the defects that we produce when we remove very huge tumors. In this first paper, we try to discuss all the different possibilities. And one of the flap that we introduced first in our experience was temporalis muscle flap that proved to be very interesting in some special cases that are demonstrated in this picture. It's a very simple and easy flap, but no question that the most interesting family of flaps are free flaps, and especially anterolateral tight flaps that we introduce in many cases. And we publish with the help of this young plastic surgeon that usually is a part of our team. We can work with many cases with a very smart reconstruction. Switching to one of the last application for cancer, we have many cancer in which we have repeated recurrence in the upper airways. In the case of this lady who had at least 4, maybe 5 recurrence in different areas, right tonsil, left tonsil, and also tongue base after chemoradiation. And by robot, you can follow any single small recurrence, removing just the lesion and sparing the rest of the mucosa. If you have to repeat many times following the surgical, field cancerization that may happen in your clinical practice, we could prove that the robot is a very interesting tool for working with this kind of problem. We could apply also robotic surgery in the pediatric patient, and with different kind of tumors, like this case of Ewing sarcoma, that is very well defined in this video, in this picture. And it proves to be easy to remove with a conventional SI robot working with 5mm instruments. Now I let Filippo to start his presentation, taking care of the problem of TORS for sleep apnea.
Okay, next. Filippo. Next. So nowadays there are many devices where we can learn the transoral robotic surgery as these DVDs. Next. Or there are papers. This paper was published on operative technique in otolaryngology, deal with transoral robotic surgery of the tongue base. Next. But it was the first book about TORS published by Greg Weinstein and Bert O'Malley. We published a chapter in this book. We really feel that this is the best book to understand robotic surgery. Next. We published this book only about transoral robotic surgery. Inside this book, published with Paul Hoff in Michigan University, US, you can find all the philosophy about transoral robotic surgery for OSA, and you can find the selection of the patient, surgical treatment, and post-operative care. Next. And you need, before starting a program, to understand how to move the robot, how to use the robot. You need cadaveric dissection. And I suggest you to go in this place, Nicholson Center in Orlando, US. And in this place, you can find Scott Magnusson, a good friend. He's one of the masters in the world about robotic surgery. You can understand everything with him. Next. Every year, we organize together with him a special course. I think it will be the first course after COVID. It will be held in March, in February, at the end of February, beginning of March 2021. It will be the 8th edition. So everyone is invited to this course. Next. So we have to operate this area, the subglossoepiglottic area, the area behind the circumvallate papilla and the epiglottis. Next. But to select our patient, we have to understand if the patient has a problem of obstruction or collapse. Next. If the patient has a problem of obstruction, we can perform TORS. But if the patient has a problem of collapse, it will be better to perform upper airway stimulation or by MAX. Next. This is the best patient for TORS. So a patient affected by a huge lymphatic tongue-based tissue. And as you can see in the MRI, the lymphatic tissue is low in the tongue base in the vallecula. Next. For selecting all the patient, we suggest to perform DISE, and performing DISE follow this paper, the European position paper on DISE. Here you can find all the steps, all the tricks for performing at the best this technique. Next. This is another paper published by our group. You have to know that in awake endoscopy, we give a strong sub-evaluation of hypopharynx obstruction. So it's important to perform DISE to evaluate the hypopharynx. Very, very important. Next. If you have this device, target control pump, it's very useful for performing in a standard way our sleep endoscopy. Next. Let's see the procedure. The definition of TORS for OSAS is a multi-level, single-stage or multi-stage procedure. We have to perform nasal surgery by conventional surgery, palate surgery, conventional surgery, and tongue-based reduction and supraglottoplasty by robot. We have to take care about all the possible obstruction sites in the upper airways. Next. But for any kind of surgery, of a transoral robotic surgery, we have to know a new anatomy, inside-out anatomy. Next. As ENT, next, we know very well the transcervical anatomy, but we have to know this new anatomy. The transoral anatomy is completely different from the transcervical anatomy. Next. So we have to study, we have performed several dissections, and at the end we could able to publish this paper about the anatomical landmarks in transoral robotic surgery of the tongue base. Next. It's really important during the endoscopic surgery in tongue base to understand where is the lingual artery. Lingual artery usually runs anteriorly and lateral to the hyoid bone, as you can see in this picture. Next. Because if you dissect the lymphatic tissue is not a problem, you have small arteries, but in our technique, if needed, we dissect the muscular layer. So in the muscular layer, you can find the lingual artery, and you have to understand where the lingual artery runs. Next. Usually, it's possible damage the lingual artery close the hyoid bone. Next. If you see this picture, you see the epiglottis, the black line is the hyoid bone, and the red cube is the area where the lingual artery runs. 2 centimeters below the surface of the tongue base, you can find the lingual artery. Next. Let's see the dissection, the technique. Next. Now I will show you some picture of the technique. This is the beginning of the technique. We use a blade to open the oropharynx, and the tip of the blade is close to the circumvallate papilla. Then we start splitting in the middle the tongue base. Next. We usually perform the right side dissection before the mucosa. Next. Then the muscle layer. As you can see inside the surgical field, there are more instruments. Next. You see 2 robotic instruments. We use always a forceps and a monopolar robotic, and 2 suctions. The suction are managed by the bedside assistant, and inside a small surgical field, you have 5 instruments, because there is an endoscope as well. Next. And now you can see the hand of the first step. We have dissected the right side of the tongue base. Next. We switch the instruments. We can move the left side and the right side without any problem by robotic technique. And we do the same on the left side. Next. Next. And we finish the left dissection. At this point, we can see very well the epiglottis. Next. Now, during this procedure, we have a visual feedback. So at the beginning of the procedure, it's not possible to see the epiglottis. At the end, we can see the epiglottis very well. Next. But we have a volume feedback as well. So we use a syringe filled by saline, and we insert our spaceman inside the saline. We have to check the amount of volume, tissue volume removed. If we have removed less than 7 cc, we have to remove much more tissue. Next. So at this point, for removing more tissue, we have to dissect the muscular tissue. Inside the muscular tissue, we can see arteries, bigger arteries. Is not a problem. Next, we can dissect and we can clip the arteries. The bedside assistant will clip this kind of arteries. Next. And you can see the spaceman. Here you can see a layer of lymphatic tissue and a layer of muscular tissue. Next. Now we have to manage the epiglottis. It takes just 1 minute. We go ahead, please, Claudio. Go ahead. We remove just the upper third of the epiglottis. Next. Very, very fast by using the monopolar of the robotic console. Go. Next. And this is the end of the surgery. So you can see how the hypopharynx now is free of tissue, lymphatic tissue, and in this way we have a more stable epiglottis. Next. This paper was published 6 years ago. It's a multi-center study, 7 centers, European and Americans. And in this paper, you can find our outcomes and complications associated with TORS in 243 patients. Next, but much more important, inside in the literature, you can find 3 meta-analyses, and all these meta-analyses states that transoral robotic surgery is a promising technique for sleep apnea, but it's really important the selection of the patient. Next. My last slide. So performing TORS for OSA, you have to study, training, take care of the patient, safety, case mix, so oncological, before benign, and then oncological patient. You have to perform sleep endoscopy. Remember, always multi-level surgery. Don't touch only the tongue base, but even the palate is important. You have to be a sleep doctor and not only a robotic surgeon. Thank you. I finished my slides. Then Claudio will finalize the presentation.
Thank you, Filippo. After that, after our experience in sleep apnea, we try to introduce many other applications. It's a paper dealing with all the possible application reported in literature that include removal of lesion, benign lesion in the tongue base, removal of lingual thyroid, and work, as you will see, in the styloid process area. We could remove laryngeal seal and we can collect a significant experience in salivary glands, stones, and different kind of lesions. So we have a wide range of application. One of that is lingual tonsil removal for many reasons. First of all, for repeating, for chronic lingual tonsillitis with different bouts of acute tonsillitis. Is the first paper that we published in 2017, and is a technique almost the same that we used to apply in TORS for sleep apnea. We just removed the lingual tonsil and we just trimmed the epiglottis. More recently, we enrolled 84 patients, and we did a more complete survey about this application. Usually, the time for removing lingual tonsil is very short, around half an hour. And we could change completely the shape of the tongue base, and we have a normal scarring in more than 94% of the patient. We could observe a keloid scar just in 6% of the cases without any swallowing trouble or any other trouble. What is interesting to see is that we could reduce in a significant way the number of episodes of acute lingual tonsillitis, switching from 4.26 per year to 0.97. That is strictly significant. And in the same way, we could reduce the use of antibiotics. That the shape, the profile of the symptoms before and after the surgery, that is strongly significant. We could also study the quality of life working with GBI, and we could demonstrate that working with GBI, the quality of life improved to a significant way. One open question was to demonstrate if you have a regrowing of the lymphoid tissue when you remove. When we approached this topic, we couldn't find any single paper dealing with this topic before our study. So we did a systematic study, and we could demonstrate in 68 patients, we didn't register any significant regrowth of the lymphoid tissue after surgery. In the 6 cases in which we could register a minimal amount of regrowth, the amount of tissue that we could demonstrate after 6 months, 6 months after the surgery, it was not really significant. Another approach that we could introduce in our routine is the approach to parapharyngeal masses. It's a typical case that we used to do. It's a small pleomorphic adenoma located very high in the parapharyngeal area. You can locate here in this imaging. And in this way, it's very easy and very short to remove the tumor, and that the result after the surgery with a couple of clips inside. But we could approach also very huge tumors like that, and it's the CT, the MRI after removal. Of course, it's much harder to remove so huge tumors, but it's possible working with 4, maybe 6 ends inside the pharynx of the patient, and is possible without any significant risk for the patient. Last in our group experience was the approach by robot to the submandibular gland excision. In the first paper that we published, 2020, it's the setting of the removal through the mouth. It's possible to do without robot, but by robot is much easier. We could also approach haloparenchymal stones of submandibular gland that is difficult to approach by a cell endoscopy. So we approach in this way, and we were able to remove very huge stone located in the verospatial place inside the duct of submandibular gland. Then we could complete our experience in submandibular cellulodenectomy, we define the way for docking the robot that is quite different than the way we dock the robot for time-based. And working with this special kind of docking, we have a very interesting view of the surgical area, and it's possible to remove in a safe way submandibular gland. Of course, we collected also sufficient experience with bilateral eagle syndrome. We are able to approach bilateral eagle syndrome in the same surgery. The key point is that you must be able to have a sufficient, nice imaging before, but the most important issue is you must be able to touch the tip of the bone before to start the surgery. If you can touch the eagle, the styloid process, it will be very easy, very safe, and very quick, the removal of the bone. We had another application, special application in patients that were tracheotomized for acute respiratory distress related to huge mass in the upper airways like that. And we could remove tracheostomy in all the patients that were previously tracheostomized in other center, and we could remove cannula, just clearing the airways working by the robot. Another very interesting application is in cases in which we failed to expose the larynx with in the setting of transoral laser approach. We were able to convert it into the robotic procedure, and a robotic setting may allow you to do what you can do by conventional laser microsurgery. In a few cases, we also applied robotic approach to velopharyngeal insufficiency. We could work in a robotic way for raising a flap of the posterior pharyngeal wall and to perform a velopharyngeal flap, and in order to prevent velopharyngeal insufficiency. We started to work also in the area of the skull base, but to be very honest, with the actual generation of robotic devices, it's not easy to work in the area of nasopharynx and anterior skull base. So in our experience, we didn't collect any single clinical cases. It was just a study on the cadaver, no real clinical case. Very recently, we published in a laryngoscope this suggestion how to minimize contagion risk in the area of COVID-19 during transoral robotic surgery. Is our last contribution in this field. What will be in our setting, in our unit, the future of robotic? We hope to be able to get very soon XI platform. So far we are working with SI. XI will be the next. And immediately after to get XI, we order also SP that is not already available in our country. If you have an idea what the meaning of a single port device is, a very short clip giving you an idea what the way of working of single port. Single port, it would be a very interesting tool for many ENT application, because the only we don't have 3 or 4 different arms. We have just one single arms, and that the scope, and they are the 3 different arms working very closely to the scope. Another goal that we would like to achieve in the future is to open to the neck, not only to the transoral. Now we are working in order to perform a facelift cervical approach. We hope that it will come in soon. We tried also in our past to work with transaxillary approach, but in our experience was not so promising, so we stopped to work with transaxillary. And in the future, we will try to apply facelift, hoping to be able to approach to any kind of mass in the neck, not only thyroid, but also nodes, but also cysts everything on submaxillary gland, everything is possible to approach through the neck. Now it's time to thank all of you for your attention, for giving us your time. But let me special thanking my team who assisted me during the last 12 years. What we did is possible because we work all together. Thanks again.
Thank you, Professor. That was quite a lucid and interesting discussion. It was quite comprehensive, and the data what you have presented speaks volumes of your work. We'll have two quick questions. First question is from Dr. Baishali Sarkar from Kolkata. You had just shown the narrow band imaging marking. Can you tell us that whether the question is how do we know that the free margin is rightly marked? So while using the TORS, do you have it handy by the side, the NBI?
Well, what we do is to perform a conventional endoscopy before to start to cut in the setting. When we expose the area, we go in with a conventional scope and we try to define the limits of the resection. After that, we switch to NBI and we mark once more, we enlarge according to the need, the surgical field. What it happened in many cases that beside the lesion by itself, we could find additional small satellite lesions. We mark also this one, and then we remove what we were able to mark with NBI, and we send it to the pathology. What we could see that working with NBI, we are much more precise than working without it. That the reason why we apply routinely in superficial cancer.
Thank you. The next question is from Dr. Kantilal Desada sir from Pune. He's a professor of ENT. How do you explain to the patients the costing of this robotic surgery? So is it insured in the country? Is it covered under insurance?
We are more lucky than you, because in Italy, robotic surgery is covered by health system. So the patient doesn't pay anything. So it's completely free for him.
Okay.
And so I don't explain anything about the cost.
Yeah.
Because for him is free. So there is not an issue for us.
Yes. So the next set of questions is for Professor Filippo Montevecchi. So while do you perform multi-level surgery for OSA with the robotic system at the same time? And if yes, whether you perform nose first and then TORS, or TORS first and then nose?
No, if you perform the multi-level surgery, the first procedure will be on the tongue base. Okay. Because if you perform nose at the first and you have bleeding after surgery, it will be difficult to see the surgical field. According to your system, you can perform a multi-level surgery at the same time, or you can delay. For example, first of all, you perform sleep endoscopy and nose surgery, and then you can perform tongue base and palate surgery after 1 month or 2 months, according to your system.
Second question for you is that you have shown that about 7 millimeter or 9 millimeter of tongue base you resect for OSA, that is obstruction type. So how does it translate to the AHI index? So how much improvement do you get on removing certain amount of tongue base?
So in our experience, we evaluated our cases and we found that in the patient where we have removed more than 7 cc, we have 70% of success. If we remove 2, 3, 4 cc, the success is inferior. First of all, because maybe the technique wasn't so good, But most important is because we didn't select the patient at the best. If you don't select the patient at the best, probably it will be impossible to remove more than 7 cc.
There is another question for you, Dr. Filippo, from Dr. Ranganath Vaidya from Pune. Can we address a paramandibular tumor by TORS?
Sorry, can you repeat, please?
So, paramandibular tumor.
Yeah. No, you mean if it's possible to
address by TORS, by robotic surgery?
There are some limitation. One limitation that we found, especially for stones in the gland, is that if you have a tumor very close to the mandible, sometimes it's difficult to move one robotic instrument because there are collision between the mandible and the instruments. But if you can manage this problem, you can perform any kind of surgery. The only problem in robotic surgery is the view and the exposure.
We will have one quick question for Professor Vicini. Professor, the single port robotic arm which you have shown looks quite fascinating. What, according to you, will be the advantage over the multi-port system?
You mean in the future, because we don't have so far the system.
Yes.
Now, the great advantage is that if you work by transoral route, you will have a very compact, a single instrument to stick inside. And from this, we will originate different arms. That's a great advantage. So easy to dock to the patient. I didn't perform any single procedure because in Italy it's not commercially available so far. But with Filippo, we work in Orlando, and the impression is that the instrument is outstanding. The only limits that may be felt is that the grasping capability of the Maryland forceps are much less than the conventional instruments because it's more tiny. And the grasping capability of the instrument is one limit of many instruments in robotic surgery, especially if we have to deal with hard tissues. Probably is one of the most important limits. And the articulation of the end of the instrument is different. So you have a different situation if we work with a SI5, XI8, and a single port. And the way of moving the tip is different, and we have to learn how to manage the different way of moving of the instrument. But it's the only, I think that it will be very interesting for special applications.
Yes. Thank you so much. And now we move on to the next set of speakers. May I introduce our esteemed Indian panelists for today. First will be Dr. Kalpana Nagpal. She is a senior ENT surgeon at Indraprastha Apollo Hospital, New Delhi. She has been a visiting fellow at Atlanta Sleep Center, Atlanta, Georgia. She has taken robotic training from Seoul, Korea. She is a robotic surgeon for thyroid, parathyroid, and snoring and sleep apnea, as well as throat cancers. She is a member of editorial board for ACTA Otolaryngology Scientific Journal. She is the first robotic ENT surgeon, female lady ENT surgeon from India. And she has the first case report of schwannoma reported from India, as well as the first in India for lingual thyroid surgery. With the huge experience, the highest number in northern India, and the big hospital center, she will be going first. Next, after her, we will be having Dr. Shailesh Kotharkar from Nagpur. He is a senior ENT consultant. He is also been trained from Seoul, Korea, and he has been doing head and neck cancers for quite some time, last 7 years. And after him, we will have Dr. Vishal Rao, who is a head at HCG Cancer Center in Bangalore. He is FRCS from Glasgow. He has 18 patents in his name. He has more than 100 publications, and he works for High Power Committee on Tobacco Control for Government of Karnataka. with much ado, I will invite Dr. Kalpana Nagpal Madam to share a screen and give us a presentation.
Yeah, can you hear me? You'll have to let me share.
Yes, yes, please. We are seeing you. Yes.
You're able to see the slides?
Yes.
Okay. And I'm audible, right?
Yes.
Okay. Yeah. Good afternoon, ladies and gentlemen. It was a pleasure to listen to Claudio, Dr. Claudio Vicini and Dr. Filippo. I mean, the experts in this field, and excellent presentations. We need to applaud them. So this afternoon, for having chosen this topic, I would again congratulate Dr. Aditya and other organizers, because it has been long since in India that we highlighted this topic. Even in our annual meetings, somehow robotics didn't take high priority. Anyway, so I'm glad we are here today discussing this. It has been 3 years since I have started this program. This is my hospital, alma mater, Apollo Hospital. It's a tertiary care center, and it's a 1,000-bedded hospital. We cater to, a lot of international patients. So international tourism is working in a big way. So, when I was listening to their talks, I was, really feeling jealous when Dr. Claudio Vicini said the patients are not paying at all and it's totally free. It's not so in India, so it's been a struggle. I'll be going through all the challenges in my slides, and of course, discuss what the goals are and what the solutions are. In fact, when I started the program, I didn't have a mentor. So I had to call a head and neck oncologist, of course, not an ENT surgeon. So he mentored me, and he mentored me only for the first case, and even for the second case, he wasn't willing, somewhere feeling, some kind of insecurity. So from the second case onwards, I was on my own. So thanks to God that we have done about 165 to 170 cases in the last 3 years. And with, experience in dealing with various cases. I'll be sharing that soon. So in India, there are only 72 robots, and you can see the number of robots in the US, and of course, Europe also, it's not bad, it's 510. So, there are lots of issues like cost issues, etc. I won't go through these things in detail, but I'll have to tell you that there is no exclusive head and neck cancer center in India. My plan was to start, it was almost materializing. And I got my mentorship from Vinci. The only, hurdle was this COVID pandemic. So hope to start someday soon. Next. So I'll be discussing about our program and where we stand in the world, and benefits versus limitations, challenges, and as I said, goals and solutions. So this is our robotic suite with, there is only one console in our hospital. I underline that and say, because so many of us share this console: urologists, gynecologists, bariatric surgeons, laparoscopic surgeons, and ENT. So the indications, and especially what we have done. So the ones in red is basically yet to do. And the ones in black, yes, we have done already. So sleep apnea surgery, the largest statistics. So we have about 125 cases. It was presented in Prague. We do a preoperative PSG and a postoperative PSG after 4 months after surgery. And we've got very gratifying results, and we maintain a feedback from each and every patient. So sleep apnea surgery is the largest, statistics that we have. Followed by thyroid surgery. Thyroid, what we have done is, initially we were doing only transaxillary approach, and now we're doing retroauricular as well. And in fact, now retroauricular is slowly taking over the transaxillary series. So we have done about 60 cases of thyroid surgery. Now, parathyroid surgery, now it was only one referral from a nephrologist so far. So that's why we only got to do one parathyroid surgery, but intraoperative PTH was monitored and very drastic improvement was shown, and it was so gratifying that anesthetist and everybody in the OT were really, happy to note the result. Now, tonsil and base of tongue cancers, again, the referral system, because we have separate department for oncologists, the referrals for malignancies have been very less, but we've had the experience of treating base of tongue cancers, and we have repeated PET scans in the last 3 years, and Again, excellent results, although the data is very less. The total number of malignancies that we've done is only 10. And so it includes epiglottic cancer, glottic cancer, and base of tongue cancer and tonsil cancer. Now, hemangioma, base of tongue, only one case, but when we published this case, we realized that the cases published otherwise in other countries were very, very less. It was 4th or 5th case. So hemangioma, it was a large hemangioma referred by my own colleague in the department. And, obviously there was no need of arranging a blood transfusion, female patient, so no scar in the neck. And the time taken for surgery was just 20 minutes because, initially the time wasted is during docking. But when you do more and more cases, the docking time becomes less, and even the surgical time is much less. So the retractor time is less. And so, there are so many such advantages, which I'll be discussing in due course. So this, a lady with the hemangioma, so it was removed, as I said, in 20 minutes, and she was discharged as a daycare patient. And now, parapharyngeal mass, we did two, one pre-styloid case and one post-styloid case. Post-styloid was schwannoma, which I recently published. And that was a challenging case because you're dealing with a mass in the carotid space. So you have all the major structures there, but with the 3D magnification, it was amazing. It gave me confidence to do the precise dissection. Lingual thyroid, now this was a patient from Nepal. It was a 16-year-old, and she kept going everywhere, center to center, because she wasn't even diagnosed as lingual thyroid. She was presenting with breathlessness, even choking spells at night. Her mother went pillar to post, and not even getting the diagnosis. She was even sent to a psychiatric clinic. And when we did an endoscopy, we found the mass. And of course, after that, after thorough investigations, then lingual thyroid was dissected by TORS. Again, similar as steps as done for sleep apnea. So she did very well post-op. And submandibular gland dissection, again, only 2 cases. Now, this was basically one patient opted because she had recurrent keloids, and therefore she didn't want a scar in the neck. So we did a retroauricular approach for this. And it was again fascinating. I think I have a clip, I'll be showing the video clip soon. Now, palatal tumor, this was a patient from Sudan. She opted, for robotics. She came for robotics specially. So again, this was the first case, but it had great, a precise dissection was possible because the palatal flaps were elevated so delicately with these instruments, and primary closure was done. So we didn't have to call the reconstructive surgeon, and she's doing so well. Chronic lingual tonsillitis, I'm not doing too many because somehow I'm not sure, how to establish and, a case, whether it is due to chronic LPR, that is laryngopharyngeal reflex, or whether it is any other cause. So I'm not too sure whether robotics is the final answer for chronic lingual tonsillitis, but we did 3 cases. Eagle syndrome, did only 1 case because I got the exposure. I mean, when I went to Dr. Scott Magnuson in Nicholson's Hospital in Florida, he said he's also doing for Eagle syndrome. So that's why we did only 1 case. Again, because of lack of haptic feedback, I do not think this is a great indication. Benign neck lesions, as I said, we did schwannoma, and also we did branchial cyst. And, these were, again, specifically patient oriented, in the sense patient asked for it, and so we went for this. Next. These are some of the pictures from our experience. So you can see how the preoperative TORS images, and see, that's the endotracheal tube, which was initially not visible. And then you slowly start seeing during the dissection that the endotracheal tube is visible. And we keep our limit as the pitch hole of the epiglottis. And then in at least out of the 125 cases of TORS for sleep apnea, we did in 30 cases even epiglottoplasty. So that's another paper I presented with. And in this, we had to, really take up cases where the epiglottis was floppy, or it was moving inwards during DISE. And so in those cases, it really benefited. And if you can see the side picture on the extreme right, the space that is created when you see post-operatively after 3 months. Now, these are the transaxillary pictures. You can see the incision. Now that's given clearly in the anterior axillary fold. What we do is we make the patient in the pre-op room itself, elevate the arm, and then mark the anterior axillary fold and mark the incision there. So that, this incision is clearly invisible after surgery. And you can see how the pictures are. 3D vision is too good for thyroids. And thyroids, of course, the main advantage is only scarless. Next. So you can see the markings for transaxillary as, and the Chung's retractor is very expensive, but in India now more centers are slowly getting it. So, but we still have only 3 or 4 centers doing robotic thyroids, but there are various approaches, including BABA. And you can see the tunnel in transaxillary approach. Actually, we raise a flap, and there is a space that's created between the subplatysmal flap and the pectoralis major. And this working space has to be adequate, more than 4 centimeters, before you insert your retractors. Again, the luxury that we don't have is, initially, except for few international patients who could afford for a 4th arm, that is the Progress forceps. Other cases we managed only with the camera arm and 2 instrument arms. So until date, we are only using those. And this is the retroauricular approach that we did for submandibular gland. And this is the parapharyngeal space pre-styloid mass. And this was a young boy, son of a gynecologist. And because she clearly knew the benefits of robotic surgery, so we did intraoral, so TOTS for parapharyngeal space mass removal. Again, because of its excellent visualization and 3D imaging, it was, we could remove the tumor in toto, and the time taken was very less. The side picture is for chronic lingual tonsillitis. So the lingual thyroid picture you can see. So the presenting symptoms were similar to the OSA. And you can see the tumor base of the tongue that we did. And typically for all the malignancies, even though it was only 10 cases, we chose only T1, T2 lesions. And this one is palatal tumor. And the entire, during the course and as well as post-op primary closure, you can see the pictures. Well, advantages of TORS, it'll be a repetition if I said, reduction in the blood loss and reduction in post-operative pain. But for the juniors, I really want to emphasize that these are all the advantages and everything has a logical reason behind. Now, reduction in the extent of cosmetic deformities, yes, for a CA base of tongue. Why not? You're avoiding commando. And you're avoiding those mandibulectomies and bad scars, ugly scars. Reduce blood loss, why? Because you're using a cautery spatula, which has both cautery coagulation mode and cautery mode. So the blood loss is minimal for most of these surgeries. Reduce post-operative pain, yes, the tissue dissection is so precise, so you're not dissecting or damaging the normal tissues unnecessarily. And so the pain is actually less. In post-operative thyroidectomies in my series, we didn't have a single patient complaining of pain. Yes, TORS, it's a big challenge. There is initial, and again, there'll be a paper that I'll be presenting very soon regarding post-operative pain in TORS patients. Somehow we have seen that in Oriental race and in African race, they did not complain of pain. At the most, the pain lasted for a day. In Indians, yes, we have seen significant pain, at least lasting for a week or 10 days. Reduce risk for wound infection. Why? Because we're not handling the tissues directly. Even in COVID, we have presented a paper and that's been published in Apollo Medical Journal. It'll be released next month. Now, this is again, it's because the staff, healthcare workers are not exposed because, you're much safer than the other surgeries that are happening. And yes, all the TORS cases, sleep apnea cases, we had only 1 patient staying in the ICU out of the 125 cases, and that too because he was an elderly male. We normally don't do cases in elderly because of lack of muscle tone, but in this particular case, because he was not, a CPAP compliant, and that's why we took him up. So he had epistaxis, and that's why he remained in the ICU. But otherwise, all of the patients with extubated post-op and no ICU stay and only 1 day stay in the hospital, no tracheostomy, no NG tube. So we only give them steroids for the first 3 to 5 days. And most of them, after they discharge, it's only oral steroids. So quicker return of speech and swallowing function has been noticed, shorter hospital stay, as I said, and faster recovery time. Now, I want to discuss and emphasize on the challenges actually. Why in India the series is less and why are very, very few people doing? We do not have hands full, we don't have even 10 ENT robotic surgeons. It's because one is, as I said in the beginning, there is no exclusive training center in India. So we either have to go to South Korea, Seoul, or go to USA, or maybe some other centers like Paris or even Italy. So insurance cover and cost to the patient. since it's an emerging economy and there's unique socioeconomic status, and mostly we talk about subsidies in our country, it's very hard to convince patients on robotic surgery. Awareness amongst doctors. Yes, we are doing it through media, but you'll be surprised. Even my own colleagues in this hospital, because it's a large hospital, we have 300 senior consultants. Most of them do not know the indications. Slowly and slowly, yes, awareness is increasing, and now our internal referrals have started increasing. Now, rigid treatment model. Yes, this is what. It's so rigid that acceptance by your colleagues, they would say, thyroid, why do you want to do it robotically? Whereas the patient satisfaction is so very important for you to justify doing this case. So acceptance by institution, acceptance by colleagues, and yes, conventional versus endoscopy, you're all the time compared. There's a lot of criticism when you start a new program. And that's why I put that panther picture, this was taken in Africa. You have to take this challenge when you start a new program, you have to face criticism, but ultimately people will start believing you. And that's how that day you're completely receiving satisfaction and gratification. And your anesthetists are your proof. Okay, next is lack of awareness. Yes, aggressive marketing is going on, but how much? India having a lot of rural population, 70% of our population lives in rural areas. So access to robotic surgeries is not possible, or it may take a very, very long time. And need of published data and cases. We have published 10 cases so far in reputed journals, like including American Journal of Otolaryngology. And well, it's still evolving. As I said, the robotic program is taking a new dimension and a new course. Hopefully we will be publishing more and more cases. And there's a credentialing criterion. Now, luckily, since I'm a mentor, I've already given credentialing for 3 other robotic surgeons, and they were part of my team, and they continue to be my team. Well, I would not take too long for discussing things like learning curve, because learning curve is required for every surgeon, to assess his or her own outcomes and compare with the previous cases, and also discuss with your team members and compare your outcomes with people in Korea or people in other advanced countries. So work scheduling and time management and material requirement, well, all these, every point here is important, because unless and until these are discussed with your team members, you cannot be running a successful program. So since I'm running short of time, I'll be even showing some videos. So I'll skip through all these implications of learning curve and parallel learning. Well, we still do not have a dual console. The day we have a dual console, it'll be good, because then that way we will be able to teach more and more juniors. So far, we have mainly observers coming from different countries, and they stay for a week here, and the stay in the hospital is free for them, and they're able to observe the cases. So managing a program, sorry, I can again skip this. I'll be showing you these slides later on. I can be shared. Ultimately, it's the entire team. The entire team has to understand the objectives. Your assistant surgeon is very important. Your bedside assistant is important. Your OT technician, your nurse, everybody is important. My ultimate goal is to have an exclusive center for robotics, and this is not possible without cooperation, with our own ENT colleagues in this country. I'm so thankful to all the organizers and people from Maharashtra, especially Pune, that you have organized this. I have some hope that this is going to be soon happening. So next, the animal lab and cadaveric lab. Yes, that's another important thing that I've written to the management, and they're saying they will be soon having a cadaveric lab. Now, all this was saying yes, just before this COVID thing started. And I hope this is not a hurdle for the program that we'll be starting. Well, TOS past, present, and future. In the past, it started 20 years ago. You can see how it has taken shape in different countries. In India, it's few at present compared to urology, gynecology, and other specialties. It's just 2%. But in future, yes, with help of smaller robots and flexi robots and more insurance covers, and some of the insurance have started slowly accepting, and even the corporates have started accepting. So hopefully we will get more and more cases. And so we will be soon, I'm sure, leading in Asia. So, well, ultimately, it's important to have a pair of human skilled hands, because human hands cannot be replaced by any robot or any other. Robots are your mere assistants, they're your friends. So now let me start with some of the videos. Thanks for the patient listening. So quickly, this is our OT video. We're using Dingman retractors. We were using initially, but Dingman was replaced by Crocad retractor because Crocad had more advantages. And now we have FKWO, so we're lucky. So that's why we have started laryngeal cancers. So it's not a bad setup for India, but soon we're going to get XI system, and we might have more than one console. So that you can see the placement for TORS. And all the TORS cases, for us, we have decided that the minimum minimum volume that is removed is 15 to 17 cc's, because that's how we've had good results. There are just 2 or 3 more videos. Dr. Aditya, I hope I have time. No, videos. Videos दिखा दो यार. Submandibular schwannoma and 1 of 3 videos titled. Sorry, just give me a minute. We're trying to open the videos. I think the first one, yeah, this is thyroid. So I'll just show you the resolution, the magnification that you have. Since it's a 10x magnification with 3D, benefits and a binocular vision. So you're seeing how the nodule looks like, colloid nodule. It is so clear. And when you're, and another advantage is you do not use any ligatures. Whether it is superior pole or inferior pole, you're using everything, you're doing it with the harmonic scalpel. And harmonic scalpel, unlike what people think, there's a lot of lateral thermal damage, etc. No, we are setting it at only 30 watts. And it is, so far we haven't had even neuropraxia. So the voice has been excellent post-surgery. And all our cases, so far we have been lucky, not a single case of hoarseness. So surgical anatomy remains the same, whether you're doing laparoscopic, endoscopic, or robotic surgery. So you need to know your anatomy well, and you need to preserve the recurrent laryngeal nerve. Next picture. I'll show you a small clip of the submandibular gland surgery where we're clipping the facial artery. These are the advantages. First, you're seeing it under higher magnification. You can see the belly of digastric, which is being retracted by the Young-Pore suction. And you'll be soon seeing where I'll be applying the clipper. Again, since, using of a robotic clipper adds to extra cost. So what we did is, apart from the 2 instrument arms, that's the cautery spatula and the bipolar, I used, hand clippers, a separate clipper, which my assistant did after I showed the vessel. Can you fast forward? Yeah, so now you can see how the clipper is applied. So the only caution one needs to take when you're doing submandibular dissection is marginal mandibular nerve. So your incision has to be clearly 2 centimeters below the margin of the mandible. Rest everything, surgical anatomy remains the same. Next. Sure. See how this is the case of schwannoma. Look at the visualization. It's amazing. You see, even though, yes, we're working in a dangerous space, now because the magnification and the clarity is so good, it helps in precise dissection. You can see the adventitia that I'm slowly separating off from the carotid. Now, you need to be very delicate. You can't be, aggressive, because you can end up in a mess. So the surgery went on very nicely. We were lucky. We could see the vagus nerve under magnification. We could see the carotid. I don't think I can show the entire video because of paucity of time, but really clearly for people who are critics, people who think robotics, is a gimmick, please understand that robotics has a lot of benefits. Yes, there are clear-cut indications, and case selection is very important. Thank you. Thank you for your patient listening. He's saying something I can't hear. He's saying something I can't hear. Minus mute or unmute? Hello, sorry, I can't hear you, Dr. Aditya.
Hello?
Yes, yes, now, yes. No, I can't hear you.
Hello? Hello,
Yes.
Aditya?
Can you stop sharing? Can you stop sharing the screen, madam?
We were not able to see the videos, last 2 or 3
you
videos.
couldn't see the videos?
No, last videos.
Oh.
So we'll come back to you at the end. I was just telling everybody that we have been joined by our national AOI president, Dr. Samir Bhargav sir also. And I would like him to say a few words about our program. Support, can you unmute Dr. Bhargav sir, please?
देखा नहीं बोल दिया
Okay, now he'll join us in some time. He just told us. Now we'll move on to our next speaker, Dr. Shailesh Kotarkar sir. Can you please share your screen? Dr. Shailesh.
Can you see my screen?
Yes, yes.
Yes, yes.
Yeah. So good evening, everybody. I am Dr. Shailesh Kotarkar. I'm practicing at Nagpur. And we have a 200-bedded tertiary care hospital. And we've been working in the cancer surgery ever since we came into the practice. It's almost 20 years. So we always felt a necessity to have something which could go in the throat, that is by transoral route, and remove the pathologies instead of giving the patients transcervical mandibulotomy and bigger approaches to serve the purpose. So we thought of the instrumentation, and Da Vinci fitted into that. And we, 7 of us, we came with the 200-bedded hospital. All of us are from different specialties. Some is urologist, gynecologist, surgery, myself in ENT, and we could get a little hand on the robotic surgeries. So Aditya, how much time would you give me so that I can finish off a couple of slides fast, or should I go according to my presentation?
8 minutes, sir. So fast slides and a video if possible.
Okay. So as we all know that we moved on from the endoscopes, microscopes, minimally invasive procedures to the robotics, which offers us the improved video imaging, and this is the most advanced instrumentation to work in the little spaces. The challenges we faced during our routine procedures were the limited range and the degree of motion instrumentation. The operative field was limited to the line of sight, lack of three-dimensional imaging, there was amplification of the physiological tremors, compromised dexterity, mismatched hand-eye coordination. So, and then came the robot. It implies the use of powered device that functions under programmable computerized control, and it may be used to manipulate the instruments and perform surgical tasks. So
can you put it on the slideshow, please?
So we also have a Da Vinci SI system, and this system, it employs the robotics to enable microsurgery in an endoscopic environment. It's a master-slave arrangement. Although the task has to be performed by you, but the robotic arms, they do their job when they're placed in case we are talking about the torch. The equipment has a 4 arms. One arm holds 0 degree or 30 degree 12 mm stereoscopic camera with 2 optical channels at each 5 mm. Other 3 arms holds 5 mm or 8 mm conventional instrumentation with endorist instruments. These are controlled by the surgeon at the master console. It provides the multiple degrees of freedom, including pitch, yaw, and roll, plus 2 additional degree of freedom in the wrist and 2 others for the tool actuation. A total of 7 degrees of freedom in all. This is the comparison of the endoscopic instruments that have just 4 degrees. As we all know that there is a vision card, the console, and the robotic card. We have the 2 control handles. This displays 2 images, one for each eye. This creates the virtual 3-dimensional image that greatly improves depth of perception within the surgical field. This is the setup. The advantages of robotic systems is it offers us the 3-dimensional high-definition visualization. The precision and dexterity offered by robotic instrumentation is far good. The fatigue reduction, as we all perform long surgeries, we get fatigue. So fatigue reduction during surgeries is the major factor which we found is beneficial to us. It restores the proper hand-eye coordination, and it allows the performance of endoscopic procedures that otherwise would be performed through an open approach. It minimizes the morbidity, improves functional outcome. Telesurgery is one of the advantages which so far we haven't started. The patient has a fast recovery, and the major function of this procedure is to get to the normal speech and the swallowing. Disadvantage is there is absence of tactile and haptic feeling, that is the sensation. The equipment size is too big and the weight is too big. We cannot shift the instrument from one setup to another. The stronger studies are needed to assess the real cost benefits of this technology compared to the other techniques. This is a new technology and has the unproven benefits. I will be presenting one case. A patient, 74-year-old male, presented to us with the difficulty in swallowing, pain during swallowing, swelling on both the sides of the neck since last 3 months. On examination, the routine throat examination, lips, tongue, teeth were normal, pillars, tonsils, posterior pharyngeal were normal. This was the patient who presented with the neck swelling. He did not have any idea of having some pathology in the throat. He had bilateral level 2 nodes. Each node were more than 5 centimeters. The rest of the neck nodes were not significant. This was the pre-operative Hopkins rod examination, where we can see the normal glottis, both piriform foci are normal. The laryngeal surface of epiglottis was normal. There was an exophytic growth on the glottic surface, which was including over the median glossoepiglottic fold and on both sides of the valleculae. As we do the normal workup, apart from having the routine workup, we had CT neck, pain and contrast, and the MRI of the neck and pain and contrast, where the information which we gathered was the tumor was in both the vallecula, and diagnosis was made after biopsy. It was the squamous cell carcinoma, and the diagnosis was CA vallecula with extension to supra with bilateral level 2 lymphadenopathy. Tumor staging was T3 and 2P and M0. We planned for the wide local excision of the lesion with supraglottic laryngectomy with bilateral modified radical neck dissection, followed by CT and RT. As we have said, that we encounter a patient usually in T4, T3 staging, where we are taking the help or the assistance of the robot, where we cannot access preliminary. So in spite of that, we are not working on the neck with the robot. We are doing neck conventionally, either selective or radical neck dissections or whatever form of neck dissections that we are doing it conventionally. And wherever we feel that we can offer this technology for removal of the tumor, there only we are using it. So to say, we are just taking the assistance of a robot in our setup. We started this program 3 years back, and in 3 years we have done around 39 patients, including the supraglottis, vallecula, brainstem lesions, radical tonsillectomies. Uh, this is the post-op Hopkins examination after 3 months of finishing the radiotherapy, where we can see the mucositis of the laryngeal mucosa. We can see the free vallecula. We can see the epiglottis and the function, the voice. And so with the assistance of the robot, we could give him the R0 clearance at the primary site, and the speech and the swallowing, which are the two important things which we achieve. So this is the so this is a follow-up after 15 days of performing the surgery, and before we started on the radiotherapy. So before we started on the radiotherapy, this patient was already having a full feed. So to conclude, robotic surgery requires a special training of the OT staff and the surgeon himself. The mass population can't afford the expenses incurred because, as Madam Kalpana said, that in our country we are not fortunate to have the insurance cover for this surgery. So patient have to bear with the cost of the surgery. So what we offer them as the assistance of the robot in particular situations where we feel it damn necessary, where we can avoid the mandibulotomy, lip splitting incisions, and getting our job done without compromising on the cancer principles. And in our setup, we are doing neck dissections in a conventional method. We are exclusively using robot for the brainstem lesions, excisions, supraglottic laryngectomies. We are doing it for CA the tonsils, performing a radical tonsillectomies or oropharyngectomies, but not for the thyroidectomies and the parathyroids and the parotids. So we haven't ventured into that because we have a general surgeons with us, those who are doing transaxillary approaches, transoral thyroids. So robots we have yet to use, and we are just 3 years younger using in these programs. So to conclude, I would like to say that this is an evolution. Revolutions yet to happen on all the fronts, like our training, our OT staff training. Governments need to understand this is the tools which should be in the armamentarium of the ENT doctors and in the other specialties, so that if the need be, they should be providing us the insurance cover also, where we have the less of the numbers as we compare to the other countries. Like where I was trained in Seoul, every surgery was being done by the robot, and they have 40 robots on one OT floor, having 45 robots, and we have a very limited number of robots. So this is just the evolution. We are just evolving out of this. Cost is the biggest factor. Secondly, the patient education is another problem. As Madam Kalpana said, that the patients and the relatives and the doctor fraternity, they are not so well versed, so taught about this particular technique, so that they can refer these patients to us, because generally before that, in our area, all based on lesions, they used to go for the radiotherapy and the chemotherapy, a sort of palliative therapy, and it was never aimed for the curative therapy. So ever since we got this gadget, we are probably doing justice to all these patients. With this, I should stop because I have many other videos. If I'm taking time, Aditya, I should go ahead, or?
I think we'll have a next talk, and then if time permits, you can share another video.
Okay, okay. Thank
I
you.
congratulate you for the excellent case discussion that you have done. It was quite an amazing result.
Thank you.
Yes. Now I would like to invite Dr. Vishal Rao. Sir, you have to stop sharing your screen, Dr. Kotarkar, sir.
Yeah.
Yeah. Dr. Vishal, you're on.
Thank you. So, thank you, Aditya. I'll just start sharing the screen. At the outset, so can I start, Aditya?
Yes, you're ready.
At the outset, thank you very much for AOI Pune for giving me this opportunity. So I will quickly get into the topic. I'm going to be talking a little brief about a simple case study and give an introduction to the topic of robotics. I'm representing HCG. We are a group of cancer care centers. We are at about 26 across the world right now. And we have at HCG Bangalore our own head and neck surgical oncology program with a separate division for minimally invasive surgery of the head and neck, which includes lasers and robotics. We have our own program, which is affiliated with the Royal College of Surgeons, recognized for head and neck surgical oncology degree, along with the state university of the state government. We also run some master classes in nature for research and academics. Now, this specific master class is actually giving training to people. It's an online course, certified course by Nature Publications as a joint initiative with us, where we help people get certification on scientific writing. We have about 36 Nature editors who come and participate in this. And it's an 11-hour course. If anybody is interested during this COVID time, we are encouraging people to come and do these courses. We are giving it free of cost now so that more and more people can utilize these courses to get certified on scientific publications. We also have our own journal, which is partnered with Walter Clovers of Journal of Precision Oncology. This is just for your information. We actively do have a separate division of minimally invasive robotic surgery, wherein we are working on several research publications on robotics. And these are some of our recent publications. We did one on technique of flap elevation, and another one is a modified facelift approach for posterior segmental mandibulectomy. Now I'm coming to the case that we're going to be presenting. This case is a gentleman who's a 60-year-old gentleman who had come to us with a diagnosis of base tongue cancer's T3 lesion, which also involved the lingual surface of the epiglottis. He was treated at a cancer center, and following that, he received chemoradiotherapy to a total dose of 66 grays, which completed in 2018 mid. Following which, he actually had his family members here at Bangalore. So he had come to us for a follow-up, and we had done a PET CT. He was on good follow-up. Now, thereafter, when we actually followed up with him, this was a very interesting thing because the lesion was actually at the center of the base tongue. I'm sorry, I've just skipped some slides here. What I'm not able to get, I'm sorry, there's some error here. What I wanted to share was nearly almost about 6 to 8 months later, he developed a recurrence at the base tongue, at the primary site. So when we actually examined him, he had developed a recurrence in that region, which is typically at the center of the base tongue. So the question with us was, this was at the original center, he was told to undergo an open surgery, which include a total glossectomy, and along with the total glossectomy, a supraglottic laryngectomy. So when he came to us, one of the things that we had discussed was about whether this would be feasible for robotic surgery, and if it is feasible for robotic surgery, how would we offset the problem of dealing with the central base tongue? As we all know that this area is going to be a difficult one. So in this particular case, we had a special discussion with our interventional radiologist, who then we did some joint discussion with them on the feasibility of trying to selectively embolize the posterior branch of the lingual artery. Now, if you study the anatomy of the lingual artery, it has the anterior branches and the posterior branches. We all know that the base tongue surgeries can be highly vascular, and hence it becomes a very difficult task for us to deal with the base tongue related surgery bleedings. So we talked to our interventional radiologist to find out if it was possible that we could actually embolize the posterior branch of the lingual artery using their small catheters. So in this particular case, we were able to successfully do it, and we've done that similarly now in totally 3 cases. The important aspect of the learning here for us was that we wanted to save the anterior tongue, we wanted to maintain the mobility, and this particular case, the lesion was measuring about 2.1 into 2.3 centimeters. So it was amenable for surgery, but it was a T2 lesion to start with, and after radiation, it was just at the level of 2 centimeters, which was very much feasible. I'm just going to get back. So a selective embolization was done in this case, wherein we were able to embolize the posterior lingual artery. Sorry. So this is the area, if you can see this blush over here. So the posterior lingual artery was then embolized, and we were able to then carry out the surgery. So this is a quick video showing the entire procedure. So the first step, I think Dr. Kalpana and others have already shown many of these steps, but what we are showing you is the simple basic docking of the robot. We use the FK retractors. We then after that dock the robotic system. And once the robotic system is docked and we get adequate exposure, then we plan the procedure. Now, typically in this setting, it's very crucial to understand that transoral surgeries, what is most desirable and why it becomes an advantage with robotic is because they have small hands and big eyes, and that becomes a crucial advantage for us to perform these surgeries. But most crucial in them is mouth opening and neck extension. If you don't have these two, you will not be able to achieve a good exposure in these surgeries to perform TORS. So one of the things which is very important as a prerequisite, like in this case that you see, is that you set up the entire system with good mouth opening and with good neck extension so that you're able to get a good exposure of this area. So typically like in TORS, we use 3 ports. One is the camera port and 2 instruments. Now the advantage in this is that if you see like in our hands, we have the left and the right hand. Now typically when we hold it, the left hand holds the forceps and the right hand holds the cautery. In these cases of robotics, what is advantageous is the left hand, in addition to holding the forceps like here, can also do the bipolar. And the right hand, in addition to holding the unipolar, you can have a scissors unipolar. So you can actually also cut. Now this is the case of the residual tumor. We have just marked the initial margin. Now very, very crucial in these cases is the margins that you select in base tongue surgeries, especially because base tongue surgeries, the chances of margin positivity is quite high. So you have to be very careful. Now this case, we did an epiglotectomy, so like a supraglottic laryngectomy and a base tongue resection. So you are seeing this is the entire base tongue. This was the lesion. So we marked using the robotics, we marked a 1 centimeter margin around it. And what you are seeing here is an unedited video. And what I wanted to show in this particular example was, look at how avascular this entire procedure is. On a lighter note, I was telling my anesthetist that these blood clots were done because of intubation, because actually speaking, post the embolization of the posterior branch of lingual artery, the overall field was so bloodless, like it was like a cadaveric demonstration. So this entire procedure, as you're seeing over here, the entire thing was so bloodless and comfortable, unlike that of a typical base tongue surgery. Now, even when we do, now most of the times we don't do embolization for base tongue surgeries, we use it as a standard technique. But in this case, being a central lesion and the fear that you will, if you hit bilateral lingual arteries, it is as though you're going to end up into a complete necrosis of the tongue, led us to actually doing this procedure with embolizations. So this is the entire each step, as you're seeing over here, we were able to get a good control. We were able to get a good margin all around the entire tumor. And as and when we kept on further progressing through the steps of the surgery, we were not encountering any major bleeds across, which showed that such steps could further ease the comfort of the surgery. Now, this is crucial because especially base tongue area, sometimes, the biggest agony that we robotic surgeons face is extensive bleeding in that region. Naturally, you can clip the lingual artery, but like in this case, our intention was not to disturb the lingual artery, especially the anterior branches or the main trunk, and yet achieve a good margin. So there are 2 things that helped us in this. One was the preoperative studying of the PET CT scan and the MRI, so that we know that we can get a good margin. Now, this is very crucial, because if you end up getting a positive margin in base tongue, it defeats your purpose. So this case was a good example learning for us on why it is important for us to pick up recurrences early. And if you catch them early, you can still salvage them through transoral robotic surgeries and achieve organ preservation. So this was the entire procedure that you're seeing over here. And you see through the entire steps of this procedure, we did not face any troubles with regarding to any bleeds or with regarding to any kind of complication. And the overall procedure took us about 45 minutes. So we send the specimen for orientation and we send it for frozen section analysis and got a clear margin of 5 millimeters, which was the closest. Now, following this, the patient was decannulated on the 7th day. Now that's our patient, and you can see that the tongue was being protruded on the 7th day. And this is the same endoscopic picture on the 7th day that you are seeing over here, the pseudovalvular and the area filled with slough. And there was minimal penetration, so our speech and swallow rehabilitation team was taking care of them. Following this, he came back to us again in the 7th month. And this is the picture of the pseudovalvular and the area of the larynx in the 7th month. Now, if you see the overall healing process, you will see, okay, here it is. So you will see in this entire procedure that this is the pseudovalvular, this is the larynx. There is absolutely no penetration, no aspiration. He was swallowing well, and this area of the base tongue had healed very well. So these are simple points to just reiterate confidence, to tell us how effective robotic surgeries can be. The previous speakers who spoke also elaborated very beautifully in the same way how feasible this can be. In addition, at our department, we've also innovated some of the things. We've developed our own robotic neck dissection retractors. Now, this is something that we are hoping to, this is the prototype we had built. The prototypes we have now started using in our hospital, because we found we were not able to get those costly Chung's retractors and others. So we developed our own retractor, which we are using very effectively. So we've till today done about 40 neck dissections now with the robotic retractors that we've developed. So I'll close with this. I just want to leave with these thoughts. You know, there was a very interesting meeting between Einstein and Rabindranath Tagore about a century back, I guess. And this entire meeting was a very, very interesting philosophical meeting where they both discussed on two concepts: world as a unity dependent on humanity, and the world as a reality independent of the humanity. And this was the two discussions they both had. Today, we are seeing a very interesting phase of machines interface with humans. And what I want to just reiterate with this entire discussion was, today we are moving towards artificial intelligence. We are moving towards a lot amount of new advances. I'm just going to show one single slide that I had actually prepared on this, which tells you. So if you see the stages of artificial intelligence today, we are at narrow intelligence, artificial narrow intelligence, and the type is the reactive machine AI, which means it's a master slave. And we are using that in robotics. But we are moving towards limited memory AI systems. So reactive AI systems are more like the Alexa, Siri that talk to us, or the Google. But limited AI is where the self-driving cars have now come in. What people like Stephen Hawking was worried about is, when we reach the theory of mind and self-aware AI, is the time we are actually going to get worried about science, and we are going to worried about how robots will take over the systems in big ways. So what's important for us is, how are we going to use our technology will define how it will help us or kill us. So I think with this, I will stop my presentation. Thank you, Dr. Aditya. Thank you for this opportunity.
Thank you so much. That was a very interesting take on AI. Congratulations for your case again. And it is the man behind the machine and not the machine, as people say. So we have a few quick questions. First, we'll have a question to Dr. Vishal Rao. How do you determine the margins of your excision when you are going in for a robotic versus conventional?
Sure. So, Dr. Aditya, now margins is a very interesting topic, especially in transoral surgery. Now, there are two important aspects to consider here. One is the surgeon factor, another is the tumor factor. The surgeon factor, we know that the more you do, the more you practice, the better you get. And this is a crucial point. With robotics, the advantage that we have seen is the learning curve is not very steep. So you can be a good robotic surgeon if you're good at Xbox and video games also, because manual dexterity is what is required. So even when we went in through the training, we spent a lot of time playing those games first before we went into the surgical OTs as observers, and then slowly build confidence with our mentors. So these three steps are very, I'm not saying they're easy, but I'm saying they're feasible and they're quick. That's very important. The second aspect is the site. So based on tumors seem to end up giving more positive margins compared to the tonsillar and the oropharyngeal other sites. Now, this particular thing is very, again, an important factor for us to consider. If you see studies that have been published, sometime back, I think 2018, there was a very nice case published on this from the Pittsburgh group, which actually talked about, from Dr. Ferris's group, which talked about in early oropharyngeal cancers. If you compare base tongue versus tonsil, you will see that the incidence of the first margin being positive, which means by the frozen section, almost 35% of the base tongues will be positive, to as high as 12% of the tonsillar areas will be positive. So 1 in 3 of them you will require to revise it. Yet, despite that, as high as 20% of them in final report in base tongue may be positive, and as high as 4% in the tonsillar area will be positive. So it's very, very important for us to see that when we touch base tongue, especially, you need to be more comfortable, and having mastered lateral area, then you should move towards base tongue.
No, we'll have one quick comment from Dr. Shailesh sir on this.
Yeah, regarding the margins when we do the open surgery, our standard textbooks of cancer surgery, the cancer principles, they say that we have to have a minimum 1 to 1.5 centimeter of a margin, tumor-free margin. But if we see the robotics and when we go through the literature where people have done the extensive series where they are recommending that 0.5 centimeter margin to 0.7 centimeter margin is adequately enough for the regional control of the tumor, and where this differs the open surgical margins as compared to the robotic margins. That's what probably you wanted to ask.
Yes. Okay, we have a next quick question to Dr. Filippo. This question is from Dr. Professor Desarda from Pune. What is the recurrence rate in malignant cases by TORS?
It's very low if you use MBI, but especially if you select the patient. I feel that the best patients are T1 or T2, especially at the beginning. Don't perform at the beginning surgery on T3 tumor, because it's very difficult to achieve the good margins.
Okay, any comments from Dr. Shailesh sir, because you have vast experience of conventional techniques as well?
As far as the recurrence rate in my series of 39 patients of base tongue, we have recurrence rate of around 23% of the cases whatever we have done. Because where we had lots of limitations, because as I've said earlier that we don't get patients in T1, T2 stages clear. We almost get patients in T3 and T4. So where we have to look for the indications and the contraindications of the surgery. So where we feel that the tumor is going up above the hyoid, if it is abutting the lingual vessels, if it is a bilateral one, and then we have to be very selective. If it is a unilateral one, we can sacrifice one lingual artery. But in case of bilateral vallecula or bilateral base tongue, you have to consider the lingual. If you sacrifice both, your tongue won't be of any use. So in those scenarios where we were very close to the linguals, on the other side, where we had already sacrificed one, there we could find that the recurrence rate was more because we couldn't do a proper tumor clearance.
Thank you so much. We have a next quick question to Dr. Nagpal, madam. What is the lateral thermal damage by the instruments used in TORS?
In our experience, as I said, transient dysphagia is known because of this. And otherwise, it's more theoretical. I don't think there is damage to any particular, like, whether it is hypoglossal nerve or any kind, because your dissection is precise and there's no such serious effects that we faced.
And in
and dysphagia. And if you keep your settings at 30 watts, as I said, I mean, this is, if you see the vision card and also the surgeon console, there are some settings that you need to learn. And there you can make sure that your cautery spatula or the harmonic scapula or whatever that you're using, even the bipolar, and try to use more bipolar than unipolar, because the heat generated is less. So that is another thing. Use your left arm more than right arm, because most of the times what people do is they use the right arm, because it's generally as a habit. Whereas a bipolar, that you use it for left arm, should be used more because the heat generated is less. And also, try to use the cautery minimally and for a lesser duration. Don't use it continuously on the tissue. More than 15 seconds, it is said, then the damage can be more.
So what is the modality that you use in thyroid surgery for ligating the vessels, like robotic thyroid surgery?
Yeah. Thyroid surgery, it is harmonic scalpel. And then, yes. And then since the harmonic scalpel has that white mark, the white will face towards the major structure, like neural or vascular.
Okay. There is a quick question for Dr. Filippo. What are the different options for robotic thyroidectomy? Is there submammary access? What is your opinion on submammary access? This question is asked by Dr. Jagdish Chandra Bose from Madurai.
I don't have experience. It's not so close to the neck, but it's possible. There is even a labial approach, so from the mouth. But the only problem through the mouth is the mandible.
How are things? Tell me, Rajni.
I'm fine, sir. I'm fine. How are you?
We are at the peak of madness. I just feel like lying to tell you everything.
Yes,
okay.
Yes, sir.
See, there are four approaches for the thyroid. One is the conventional one, where you can do horizontal or the vertical incision. There is another approach for transaxillary.
Just a second. Dr. Seema Apsar.
Yeah, broadly in Mangalore, but I think everywhere many people have lost the plot.
Dr. Seema Apsar.
Yeah, I don't know what is happening with contact tracing.
Yes, sir. Dr. Shaileshwar, please.
Yeah, there are four approaches, as I was saying. One is the conventional one, to the neck, transcervical. Second is transaxillary, transmammary. And latest one, we also have been trying to do this transoral, where we can use the conventional laparoscopy instrumentation, where we have these 9 mm ports, one central port and the 2 lateral ports. There are the smaller ports, 5 mm, from wherein the instrument goes, and from the 9 mm port, the camera goes in, where we have to go subplatismally, go on to the thyroid. But there are certainly many contraindications for this. As I've said, the place is very less, where you can have the 3 centimeter nodule that can only be accessed through the transoral route, where we try to do a little bigger nodules, wherein we had to open it up. We had to give it on the transoral approach. So there are only 4 approaches for the thyroid.
Okay, thank you so much. Now we have 2 quick questions for Dr. Vishal Rao. Hello, Dr. Vishal?
Yes, I can hear you.
Yeah, so the next obvious question is, instead of monopolar cautery, can we have an arm in which the coagulation also goes and make it more useful?
So, Aditya, I don't know if you talk to Da Vinci, and today I think there are about 18 robotic systems that are in the market, which are trying to penetrate the market, but each one of them trying to innovate and put some patents on a new area. So Da Vinci did try this with bringing in lasers, okay, and trying to integrate lasers into it, but it did not succeed in the first few attempts that they did. So there is surgeons' desire to say that we want this and we want to additionally add an instrument or an angulation of the instrument. We keep telling them about this, but what seems to be a logjam between the surgeons and the manufacturers is that they have some plans that they are not ready to deviate from. I think that's my personal opinion. it's desirable for us. The second, I think, is in terms of entry. The space is so restricted that if you want to add anything more, you're going to be able to you're not going to be successful in achieving your results there. So I'm sure the other surgeons here will also have their opinions, Shailesh, Dr. Kalpana and all. But the biggest problem has been our desire to add instruments does not reciprocate with the manufacturers.
Okay.
And
There are quite a few.
Da Vinci is probably incorporating more expensive things. They are trying to incorporate harmonics instead of the cautery. So that will become again a costly affair.
There are quite a few interesting comments on the chat box. People are asking what is the scope of completely automating a surgery and what is the limitations. So a robo will be performing the entire surgery, and wherein the CT scan, MRI, all data will be pre-fed, and the precise cuts will be taken by robo as is done in robotic knee replacement surgery.
Yeah, that is why my last slide already said that human hands cannot be replaced by anything else. So artificial intelligence, even to this extent, should not be allowed in our surgical field.
So Aditya, I just want to share one quick slide that I had put something on this. I just want to share a very quick one.
Yeah, in the meantime, there is a quick comment from Dr. Munir from Pakistan. He says that there will be a time where stapes surgery will be totally taken over by robo because of the safety and minimum tremors.
So Aditya, this is the slide. See, this is a very interesting paper that was published in the Lancet Oncology Commission on the cancer moonshot. And they talked about 5 technologies that are going to change the way cancer is looked at in the future. One of them was enabling technologies. If you look at health 2.0, now industry is at 4.0 and health 2.0 is currently here. We are looking at digital diagnostic, IoT. These are the 12 interesting areas where the future, the next 10 years will be there, health. And if you see what that question somebody asked, it relevantly talks about these 12 areas and integrating it. And already Google and a couple of others have tried to look at IoT systems wherein the robot systems talks to the OT table, which talks to the anesthetic machine, which talks to the surgeon's wearable. These are all things that are already ongoing. I just wanted to bring that slide up just to talk and give that answer. I think already a lot of people are going, and I just want to quote one single thing. I was in a group on a panel discussion with Stanford group engineers, and one of them very fervently said, give us 10 years and we'll make the doctors redundant. So I was the only guy supporting them, and I was laughing, I was telling them, look, 10 years from now, there will be MTech in oncology, may not be MCH, but we'll still be there on the other side. Don't worry, I told them, This thing about replacing a doctor, finally you'll have to work with humans only. Whom are you going to replace at which point is going to be related.
Madam, any quick comment from you?
Well, more and more youngsters should be working towards taking up robotics. It's not difficult because a lot of people have this initial difficulty in finding the center, etc. Probably they can observe one of us and then take up this seriously because we need more robotic surgeons in India as well.
Dr. Shailesh, sir?
Simultaneously, we need to sensitize the government machinery here because on their front, they are not so enthusiastic to promote this type of a invention in our type of a scenario where we are happy giving subsidies, but we are not happy giving funds to the newer technologies. So we need to sensitize government also. I hope the Indian panelists would agree with me.
Yes, sir.
Last word from Professor Filippo.
So we are at the beginning of the robotic era. I'm quite sure that in the future there will be much more platforms, robotic platforms, different kind of robot and cheaper platforms. So we have to wait the technology and the development of the techniques. But for sure, robotic surgery will be one of the future field of medicine in the next years.
I see that in next 5 years, probably pituitary and anterior skull base, the bone drilling as well as coblation and everything probably could be incorporated in the robo arm and even in endoscopic ear surgery. Now, cochlear implant is also been aided by the robo cochlear implant, but I think in near future, anterior skull base will also be taken up.
You know, Aditya, many things need to be incorporated as far as the surgical dissections has to be considered. We need to have the intraoperative, like what we use the carotid Dopplers, like Dopplers inside. We need to have the harmonic scalpel inside. We have to have the cautery inside. So the different types of options, if they are available, then one won't have a fear of working near the carotids, wherever, right from the base skull to the neck. And probably that will have the real vantage points rather than going for the conventional surgeries then. If we have all the armamentarium through the same channels, that would be far, far better.
Dr. Vishal, a quick comment from you because there is one comment from Mr. Mohan that he says that if not fully automated, how about AI-enabled robotic assisted human surgeon? So how is, yeah, so
I think so what we need to know is that AI was the beginning of robotics. So AI came to us early in the 50s, and robots came in the 70s, and the first human robots for healthcare came in the 90s. So if you see the timeline of it, AI came first, and without AI there would be no robots. So there is going to be interplay between two of these topics, and what I showed in the earlier slide, the types, the stages, and the things are actually all representing artificial intelligence. So if you see the spectrum of this, this is what we are progressing to. So we started with Alexa, Siri, we are moving towards self-thinking cars right now. So we are already progressing, and this is what exactly Stephen Hawking said, that we will reach theory of mind. It's just a matter of time. We will reach theory of mind. So it's just that it's going to be time bound, and all of these are going to come as phases as we advance technology.
So would you like to tell the robo that, okay, take an incision 5 millimeter lateral to this point, or you yourself will like to do it?
No, what I'm just learning is acceptance and adaptation. That the biggest achievements of today will be considered the biggest blunders of tomorrow. So we don't know. I really don't know whether to say right or wrong for any specific thing. But all I can say is we are adapting, and I'm seeing that we did not embrace robotics when it came in, but slowly we are starting to realize that there is a space, like Dr. Kalpana said in her initial slides, talking about how we are all looking at each one of those areas. But again, the questions are, how is it going to be beneficial for the patient? Will it be able to reduce costs? And how is it going to, whether it's going to help us with shorter stay, better outcomes? These are questions that still linger in front of evidence, in front of policymakers, in front of larger institutions, and that is where big questions still lie.
So with this, I would like Dr. Sharmela madam to summarize. This will be followed by one quick word from Dr. Vijay Sonane sir, and that will be followed by one video from Kalpana madam. In the meantime, madam, you please arrange your video. In the meantime, Dr. Sharmela and Dr. Sonane will have a quick comment, and then we'll close with your video sharing.
At the outset, I would like to thank the Pune branch of the AOI and Dr. Aditya Yevlekar for organizing this webinar, which has been a very informative and powerful session and provided valuable insight about the current status of robotic surgery in ENT, with the expertise and experience shared by our eminent international faculty, Professor Claudio Vicini, Professor Filippo Montevecchi, and our national faculty, Dr. Kalpana Nagpal, Dr. Shailesh Kothalkar, and Dr. Vilas Rao. I have had hands-on experience with the intuitive Da Vinci system and the Robotic system. The future of robotic assisted surgery, I find, may be incredibly exciting. I presented a poster on robotic health therapy, which was appreciated by Professor Hoi Chose at Carnegie Mellon University in 2014 and by Professor Gregory Weinstein in University of Pennsylvania in 2015. It provided the scientific basis for future translational research related to vascular and cellular targeted, minimally invasive, fluorescence-guided laser photodynamic therapy for head and neck cancer using the robotic platform. The Flex robotic system utilizing Snake Robos, a robotic navigation steering system and virtual incisions, robot-guided placement of electrodes during cochlear implant surgery, and are all innovative surgical procedures being considered today. My interest in robotic surgery was sparked by an article about telerobotic surgery, and the concept of telemedicine and terrestrial telesurgery has progressed to telerobotic surgery and telementoring across continents, paving the way for medical care in space via telerobotic surgery. On this futuristic note, I would request Dr. Yevleker to propose a vote of thanks.
So one final word from Dr. Vijay Sonone, sir.
Hello. It was a very enlightening session on robotic surgery, the present and the future. I thank all the panelists, Dr. Vicini, Dr. Filippo, Dr. Shailesh, Dr. Rao, and Dr. Kalpana for their valuable presentation and enlightening us on robotic surgery. Robotic surgery is the future for two things. One is for precision and better outcome. Definitely for areas where we are not able to reach. So I think the new generation or the younger generation to go and take up robotic surgery. And Dr. Kalpana, as she said, she's starting a center for training in India. So that is a welcome move. I give her all the best, and I hope the new generation take up robotic surgery. Thank you.
Madam, over to you. Can you share your screen, please? Yes, we are able to see.
Oh, you can see now? Okay.
Yes, yes.
Now, this is the case of schwannoma that I did last week. Sorry, I think 2 weeks ago. Now, first of all, young female, and again, because of cosmetic reasons, as well as I thought, the dissection would be precise because of its excellent magnification. So took up, retroauricular approach, and tumor size was 5 centimeters. And of course, CT, MRI, everything was performed. And MRI said, patchy contrast enhancement, and it was more pointing towards schwannoma. Well, now, we had to certainly be aware that during the procedure, if anything happened, any mishap, whether it was injury to the, internal jugular vein or vagus or anything, this is, certainly going to be a disaster and unwanted also, because it's a benign lesion and you don't have to create such things. So one thing was sure that, from start to the beginning, start to the end, we had to do it without any complication. So started off, and this was the first experience, as I said, for a schwannoma. Now, excellent magnification. Now, the Yankur was kept only to retract the sternomastoid. Is the video moving? Maybe it's slow. Okay. So if you can see the tumor, yes. Now, first you separate the attachments with the muscle, if at all the sternomastoid fibers are still attached to it, you separate it off. And then you always, the tumor has a capsule. You have to make sure that this is applicable for anything, even if you're doing a thyroid, you're not supposed to be entering the capsule. And that's when you'll encounter the bleeding as well as, the spillage of the disease. So this is very, very important. Now, the advantage of doing schwannoma under robot assisted was seeing the vagus, which was very well magnified, and the carotid, which was clearly seen, it was lying between the two. So you could see the carotid pulsations each time, and you could see the vagus also. So now, while you're dissecting, of course, smaller feeders had to be cauterized, and that was happening easily with the harmonic scalpel. So the advantage of harmonic scalpels made us, not encounter bleeding. It was dry throughout. The field was dry throughout. So this is the main advantage. What happened to the video? Again, sorry, there's some issue. Again, the video has gone off, but this is what is it coming back?
Yes. Yes.
So surprisingly, the entire dissection time took us only 1 hour. And you could see, you know, this thin layer of the adventitia, this is actually between the tumor and the carotid. Now that could be easily separated with these instruments. I mean, it was very carefully done, of course, but at the same time, it was gratifying when it came out nicely in toto. And one humble request to the AOI is to actually encourage or meet up with the directors of all the insurance companies so that we in future can do many, many more cases and insurance gets covered for all this. We certainly have to, you know, normally what happens, all these corporate heads also, you tell them, but they don't take this. I mean, you tell them all the benefits, but they're not convinced. So we have to together do it and then it'll probably work. So thank you all for the opportunity.
Thank you so much, madam.
Because it's a long video. I mean, I wish I can show you the entire one.
We have, due to constraints of time, I don't think that is possible. But thank you so much for your participation. And thank you, Professor Filippo Montevecchi. Please convey regards to Professor Vicini, Dr. Shailesh Kotarkar, sir, Dr. Vishal Rao, Dr. Vijay Sonone, our moderator, Dr. Sharmela Sondhi, and Team CIPLA for giving us a platform on CIPLA Orient on Facebook as well. And with this, we come to the end of the meet. Thank you so much.
Thank you. It was nice meeting you, Ma'am Kalpana.
Thank you. Same here. Very nice meeting you all. Thank you, Dr. Sharmila. And thank you all.
Thank you, everyone. Yes. Wonderful session.